Welcome to Quick Medical Review. Today, diabetes mellitus type 1 in under 5 minutes. Let's go. Buzzwords first. Autoimmune destruction of beta cells, absolute insulin deficiency. Anti-GAD and anti-islet cell antibodies serologic markers. DKA, the feared complication and sometimes the first presentation. C-peptide low confirms no endogenous insulin production. Insulin, the only treatment always required. Let's break it down. Type 1 diabetes, an autoimmune disease causing destruction of pancreatic beta cells. This leads to absolute insulin deficiency. The patient cannot survive without exogenous insulin. Pathophysiology: autoantibodies destroy the beta cells. By the time of diagnosis, about 90% of beta cells are destroyed. Key antibodies: anti-GAD 65, anti-islet cell, anti-insulin, anti-IA2. Demographics: typically presents in childhood or adolescence, but can occur at any age. Peak onset around age 10 to 14. More common in patients with other autoimmune conditions: Hashimoto thyroiditis, celiac disease, Addison disease. Presentation: rapid onset polyuria, polydipsia, polyphagia, and weight loss. The 3 Ps plus weight loss. May present in DKA, diabetic ketoacidosis, as the first manifestation. DKA, insulin deficiency leads to uncontrolled lipolysis. Free fatty acids are converted to ketone bodies, beta-hydroxybutyrate, and acetoacetate. This causes anion gap metabolic acidosis. Presentation: nausea, vomiting, abdominal pain, Kussmaul respirations, deep rapid breathing to compensate for acidosis, fruity breath, odor from acetone dehydration, altered mental status. DKA labs: blood glucose usually above 250 but can be lower euglycemic DKA. Anion gap metabolic acidosis, low bicarbonate, elevated beta-hydroxybutyrate, elevated anion gap, hyponatremia dilutional. Potassium may be high on initial labs despite total body potassium depletion because acidosis shifts potassium out of cells. DKA treatment: intravenous fluids, normal saline aggressively the first step, intravenous insulin drip after initial fluid resuscitation. Potassium replacement: start when potassium is below 5.2 because insulin will drive potassium into cells. Hypokalemia is the leading cause of death in DKA treatment. Switch to dextrose-containing fluids when glucose reaches 200 to prevent hypoglycemia while continuing insulin to close the anion gap. Monitor glucose and electrolytes every 1 to 2 hours. Diagnosis of type 1: fasting glucose above 126 or random glucose above 200 with symptoms, or hemoglobin A1C above 6.5. C-peptide, low or undetectable, confirms no endogenous insulin. Treatment: insulin always required, lifelong. Basal bolus regimen: long-acting insulin glargine or detemir once or twice daily plus rapid-acting insulin lispro or aspart before meals. Insulin pump, an alternative, provides continuous subcutaneous insulin infusion. Continuous glucose monitoring: continuous glucose monitoring improves glycemic control. Target hemoglobin A1C below 7%. Example: type 1 equals autoimmune, absolute insulin deficiency, C-peptide low. DKA anion gap acidosis: treat with fluids first, then insulin monitor potassium closely. Hypokalemia kills in DKA. Anti-GAD antibodies confirm autoimmune etiology. Insulin is always required. That was diabetes mellitus type 1 on Quick Medical Review. Study smart, not hard.